name is Uli Wittchen. I'm coming from the Technische Universität in Dresden. I'm heading there the Center for Clinical Epidemiology and Longitudinal Studies. And I'm a clinical psychologist by training. I started already working in psychiatry for many years. And what I'm really interested in is finding out what makes people mentally ill. So I will talk about some of my research over the last 25 years or so, where we were looking into the question, why do people develop mental disorder, when they're going to do it, and what are the core factors deciding that some people go along in their life without major problems, and why some people develop things like major depression, anxiety disorder, substance use disorder. So my talk will be giving an overview of the type of research, the methods, and the problems and challenges involved in that type of research, and I hope it's going to be an interesting experience, and I can answer some of my core questions that you might have to me. Thank you very much. It's a great pleasure to be here today, and I'm very impressed by your networks and the many things you are doing here, and changing really the scene of mental disorder research in France. So it's really exciting, and I hope I can give you some interesting ideas. And I didn't know what to do really here, so I thought I'd make two parts. One is basically introducing a little bit the study here, and that's going to be like, I don't know, 10, 11 slides, and then maybe if you have any questions regarding logistics, the methods, our aims and procedures, it's maybe a good point then that we break maybe for a few minutes to answer some of your questions before I can present you a few examples of our findings. And I've prepared two kinds of data or results. One is more on the question of what are risk factors for the beginning of substance use disorders. And the other example is more what is the contribution of familiar aggregation to the development of mental disorders. So depending on the time, we might drop one or the other topic or make one a little bit less detailed than the other one. So, it was many years ago when I was still working in Munich that I tried to develop a clinical epidemiological program where I basically wanted to find out why people develop mental disorders. And my interest in mental disorders was not so much schizophrenia or bipolar disorders in the beginning, but I was more interested in those mental disorders that typically can be seen in adolescence, like the beginning of substance use disorders, the beginning of anxiety disorders, the beginning of eating disorders, first episodes of depression that are not clinically that significant maybe. So the idea was to find and define a network of collaboration to have a study designed that is large enough to describe the evolution of mental disorders from ages of childhood into adulthood. So it's basically a time period that we wanted to cover of about 10 years. And we were very lucky through various mechanisms, like the federal government was interested in that, foundations were interested in that, to get enough funding to start the study. Now, this is about 20 years ago, 25 years almost, and since then this has developed as a very broad program. It's not a study anymore. There are people working on early signs of schizophrenia and the frequency of psychotic symptoms in adulthood, and others work still on the original questions of eating disorders, anxiety disorder, and depression. So the core questions that we wanted to find out is, what are the vulnerability and risk factors that determine that a person develops a first mental disorder? could be ADHD, it could be anxiety disorder, it could be depression, it could be eating disorder, whatever. What determines after the onset of this disorder that the person continues having it or remits spontaneously? So some people have a reoccurrence of the disorder, and some people have a persistent problem, which is getting more and more complicated, including comorbidity. Like you start with social phobia problems, you develop social phobia, you get panic attacks, you get panic disorder, you end up with depression after a couple of years. And that is what we call symptom progression modeling. So in this context, we wanted to see whether, similar to other areas of medicine, where people start with a, well, clinically not necessarily dramatic problem for some time, and then because of the subtle changes in behavior and the pathophysiology, the thing's getting worse and worse. Just think about this scenario of hypertension, diabetes, cardiovascular disease, nephropathy, and things like that in medicine. So the idea was basically to say, what are these early syndromes that we clinically sometimes don't take that serious, and why and when does it flip into something clinically significant? And as part of this, we also, from the very beginning, actually did a lot of genetic analysis to look into gene-environmental interactions. If you go through our publications, you will see that there are very few publications from that study directly, because we switched actually in year 6 from genetic to proteomic type of research. So basically we were building up the resources within the study to do a lot of more innovative work, and so I will talk about genes and gene-environmental interactions today, because it's a topic that we have really departed in the more traditional way. So if you want to have a graphical display of what we want to do, is basically we wanted to see, starting with the examination of the parents of our subjects that we follow, what are the early expressions of psychopathology? When does it start and why does it start? And then how does it go on? Is it getting worse? Is it getting a persistent problem? Is it waxing and waning? Or do people remit and have it just for a couple of months? And you see the ages that we are focusing on is pretty much age 14. And at the end of the study now, we are able to cover the ages 34, up to 34 approximately. And the factors that are here in front are what we call vulnerability and risk factors, so which could be genetic, could be familiar factors, temperament, triggering events, life changes, childhood disorders, etc. And then later on, what we measure as outcomes is basically functioning, is psychopathology, is demoralization, self-medication, and so on. So that's the model, basically, that we had in mind. So if you want to study that, you can't work with clinical populations. So I can't just go into my outpatient unit and say, well, give me any person that comes in because of panic, of eating, or depressive syndromes, because these people have it already. So in that case, I have to go back, basically, and do retrospective research. We also didn't decide for a high-risk cohort, because 25 years ago, our knowledge about what are the risk factors and what is a good definition for a high-risk population was not that good. So we felt that doesn't work in any way. So we decided basically to do what we call a general population survey. So in Germany, what you can do is you can go to the inhabitants register, and everybody living in Germany is registered there. So I can say, I want to have, in that case, 3,000 people aged 14 to 24, and I need a representative sample of all registered people in the age range of, let's say, 14 and 15. And I need, in terms of power, let's say 600 or 800 aged 14, and I need 600 aged 19, and so on. So it's kind of a birth cohort that you define here, because we know, and by the computer I get told, okay, there is this Uli Wittchen living under this address, and he was born 6th of July 51, and you know everything about that person in terms of these formal characteristics. And then we write them a letter and we invite them to participate. And 25 years ago, and with the expertise we have, we pretty much were able to cover 75% throughout the study of this random sample of the general population. So it's not a help-seeking patient population, but it's a random community sample picked from the inhabitants register. And this all covers the area of Munich, which is 1.6 million, rural and metropolitan area. And we took 3,021 over sampling the young ones, because we assumed, okay, among the 14 years old, maybe just 10% have already a problem, but 90% have not a problem. So we were pretty sure that among the very young people, we still have many who have no mental disorders. Whereas among the, let's say, 21 years old, we pretty much knew from previous study that maybe up to 25% have or have had some problem with mental disorders. So, and then once we had this, of course, with 14 years old, it's getting tricky, because you can't ask the 14-year-old, would you like to participate for the next 10 years in annual time intervals and come into a psychiatric hospital for examination, because you have to ask the parents. So what we did basically is we told the parents what we want to do, and that this is a very rare opportunity, and offered them also a checkup on mental health, on stress, resilience in the family. So we asked all participating parents, mothers and fathers, and sometimes even the extended families, to also participate. So basically we examined, starting with the sample population of 14 to 24 years old at the beginning of the study, to examine both the 14 to 24 years old and the parents, and sometimes the whole family network. We did that mostly at home, in the parents' house, for various reasons. The first one is, if you want to know what actually is going on in such a family, it's better to be at home. You can ask, may I use your bathroom? You can have a look at what kind of medication is standing there. You see how dirty it is, how messy it is. You see, what's going on, how many children are around, how stressed is the mother. So you can get a lot of behavioral protocols from these families. And if you do this several times in the study over time, you get to know the family pretty well. This is a difficult thing, however, because these families, they're like our interviewers, which come in the course of the study up to 10 times in their house, whether they like it or not. But of course it's difficult to have interviewers who stay with a study 10 years. I can't pay a person 10 years and say, okay, you now from this year you will be responsible for these 50 or 60 families in our study. So it's always a big problem to find a core set of researchers that stay with the study and keep the personal contact throughout the study between the scientists and the families and the kids. But it's also very important here to involve these people in recruiting new staff members that come in and come out. So overall we have like 250 interviewers that have been involved in the study. 250 people who have to go through the training, the behavior protocol, what to do and not to do, and it's a tremendously complicated thing, as you can imagine. So the core design was that we had a baseline study in the year 1995 where we examined the 3,021 young adolescents and young adults, and we had from the total population registered 72% who participated. And as you can see, actually the numbers didn't change that much in the subsequent wave. I didn't include the last wave actually here for some reason, I don't know why. But pretty much, although sometimes, you know, the person was not interviewed at the time where he needed to be interviewed, for example, because a 17 years old went to the United States to study and was not available. But a few years later, 1 or 2 years later, he was back in Germany, and then we could do a full interview and get a new blood sample, for example. But overall, actually, we could retain approximately 2/3 of the original target population in the study, which is for Germany an excellent finding, because there's a lot of discussion on issues like what do you do with data and should you trust scientists. What is important is it's a stratified sample, which means when you read papers from that study, it always says weighted numbers. So you have the raw number, like you have, let's say, 400 people with alcohol use disorder, but then there is a weighted number, and this weighted number says 320 or 520, which means depending on where the subject was sampled and when it came from the young ones that were oversampled at twice the rate of the older one, you have to later on weight down this factor. Not necessarily in all studies, and since you are all involved in cohort studies, you can use this data, for example, by saying, I exclusively want to study the cohort of 14 years old, and define, let's say, the 800 people all born 14 years before 95 in that particular year, and say, I want to study what happened to people born in that particular year, 81, and want to see what happened with them 15, 20, 25 years later. And then you need no weighting, of course. But if you look at some of the study populations where you say what is the overall probability of something, then you would use these weighted data due to the stratification of the sample. Now, all participants actually went through a pretty hefty assessment program that included standardized computer-assisted clinical diagnostic interviews, where they have to fill out scales, but it's mostly a conversation that you're doing, a standardized conversation where clinical interviewers basically ask for things like anxiety, life course, etc. We were pretty much oriented towards DSM-4 criteria, including dimensions, which means we always had for each criterion dimensional measures from the very beginning because of our interest in fluctuations of the symptom. And these interviews were basically done with the parents and the children. So the same interview were done in all subjects, which is a big advantage for the analysis. So this is basically the design, and let me just spend 1 minute so you can understand what's going on. I understand that your cohort studies you're doing, they are somehow coming out of this part of the population. You work with treated patients or patients who are in contact in some way with institutions. We work basically with people from the general population that might include these subjects, but basically include predominantly people who are not in contact with services. Yeah? So here you have a cohort study of treated patients. Here you might have, let's say, a study where you sample in primary care certain people. That would be a cohort study of untreated cases. But the study I'm talking about is a study in the community, in the general population in this particular part. So, so if you look at basically the structure of the data that you get from this study, it's a pretty complex thing. And it's very important to understand that handling such longitudinal data is a very tricky thing where you really should spend a long time to think about how do I build the data file. We decided to do it the following way. We said, okay, one set of data is what we call the family genetic studies. So this box contains all information about father, mother, other family members, both direct interviews and family history data, and their blood. So this box is, let's say, let's call it the family pool. The data of the subject himself, the kids, is not included in there. The second box is called subject childhood development. That's history data. So we got the birth protocols, we got the mother passport, what is being used for this for the kids. We got all the data from doctor's visits, from diseases, from all consultations the person had the first 13 years of life. And then the interview with the subject basically started at this point when the person was sampled. Like a 14-year-old would have been asked about current symptoms and problems in the past 12 months, as well as some information about lifetime. Yeah? So for example, when school performance questions came up, then it was asked, did you ever had problems in school, or can you remember what happened when you were in the first, that kind of thing. And then, of course, the trouble is you do the first interview, and let's say 1 year later you are re-examining the person. It's getting really tricky. Because let's say the first interview was done on the 1st of May in '95. Now, a year later you come to the person, we are on holidays and whatever, and you end up doing the interview in July. So not 12, but 14 months later. So there you have to adjust basically, when you want to see what is the 12 months rate, you have to adjust it for the time interval. So basically there you can't work with 12 months anymore, you work with 14 months. But does the person remember? If you ask, the first time, let's say, well, I sometimes have a lot of problems with school and performance situations. And then you come later and you ask the same questions again, and the person says nothing about it. Does it mean it's gone? So what should you do in that sake? Should you maybe say, the last time you told me about problems you had in school, whenever you are called by your teacher, you get this nervousness, you get a red face and sweat and can't think very clearly and you tremble. You didn't tell me this time about it. Does it mean it's gone? It's an interesting question. Should you do this or should not do it? Are you stimulating psychopathology by forcing recall? Well, we don't know. What we have done, actually, in our study, we have not done it in the core interview, but we had what we call a review section at the interview, once it was completed, where we asked the person, okay, we are done for today, but let me ask you 2 questions. You didn't tell me about, and then we asked the things that they have been telling us before, just to find out, was it forgotten? Was the person under stress and didn't want to tell us, or was there really some remission? But it's very, very important to look at this, because if you look at incident, new occurring problems, that is where most of the variability comes in research from, because people differ in the way they do such examinations. And as you can see, this is the way we did it in all the waves. In all the waves, we took the blood. It was very interesting, taking blood, in the household and the families and taking blood every time. It's not only once, you know, you take it every time because we wanted to see changes. And it was a bloody thing, yes. So you end up basically with things like that. You build up now a data file, person by person, by year. You're not only, you know, aggregating the information, but basically you say, that person in year 2, in year 3, in year 4, 5, 6, 7, and so on and so on and so on. It can go on to 34 years. What was the status of each syndrome, of each clinical syndrome in that particular year? Yes or no? That person had sleep problems treated by a child doctor from year 2 to 6, and then it stopped entirely. There was nothing recorded and nothing reported by either the family or the subject after age of 6. However, by age of 10, the person had suddenly an animal phobia. Nothing before. And it went on until, this was the last examination in that particular case, and it went on to be a severe animal phobia. Person couldn't touch it, would go to on the other side of the street if a dog comes by and things like that. By age of 12 to 19, social phobia, pretty much persistent, some fluctuations, and then by age of 12, a dysthymia onset, which by age of 17 resulted in the first episode of major depression that needed to be hospitalized for about 2.5 weeks. Because of a suicide attempt. Now, as you can see, now you have a data set where you have 3,000 people plus information of mother and father as, let's say, the familiar genetic risk factor that you might like to look at later on. And for each of the years, you could now say, okay, the outcome here for age 9 and 10 and so on, they would be pretty normal, nothing, no severe psychopathology. But if you would say, what was the outcome of that particular person at age 18, it would be 3 disorders. A depressive disorder, a social phobia, an animal phobia. Now we have a total of 62 diagnoses in this study. So this I do not show all the syndromes we are looking at, but as you can see, actually, it can be more complicated. So here's a case with neurosis in childhood, and then panic attack, situational phobia, social fears, generalized social phobia, MDE, and then a second episode here, which is going on. So that is the data structure. And it's in these kind of studies, so what you get is you get what we call person by year data file. Very important to keep that in mind, because person by year data files are an extremely elegant methodology to model later on longitudinally the data. Without preparing the data from the beginning in such a way, you're lost. Yeah, you're really lost, because you will never have the statistical power to do sophisticated analysis and to test the interactions of factors. Because basically every person is not a person, because you have always a person multiplied with 34 years. Yeah? So a person has what we call a nest factor in statistics, a nest factor that allows you actually to have a cluster within the cluster. And that gives you a lot of options for modeling the data. A second thing that is, for this kind of study, extremely important is that you basically separate the layers of a person over time. So you have matrices, basically, for each of the years again, where the person, let's say, think about this as being different layers of waves. So this was the baseline examination, and this, let's say, is the next follow-up. So it may well be that the person has no symptoms at baseline and no symptoms at follow-up. You know? So if you have just 2 examinations. Now think about, you have 4 or 5 or 6 examinations, then what you get is you get these squares for each of the waves, where in one case a person is completely normal, having at no waves any symptoms. And in our study this is very few people actually. Have a guess, how many of our subjects were completely free of clinically significant symptomatology? Well, it's clearly less than 40%, right? Clinically significant psychopathology belongs to us. If you follow up people year by year and observe them in their life, you will see that everyone goes eventually up to age of 100 or whatever you might get through some severe symptomatology. Some just a few weeks, maybe a few months, and sometimes people end up having it all their lives. But again, this is very important, so we can separate basically and model the course of these disorders over the waves. So you see the fluctuations, how many people you know have something and then later on progress either to become a threshold case or get better. And to give you an example, for one area here, for substance use disorders, we would say, okay, how many people, let's say, have no exposure to alcohol or nicotine? And at what age they make the transition to be experimental users for a certain drug, at what age they become regular users, at what age they become dependent users and having the full syndrome, and when do they meet fully the threshold criteria for, let's say, a dependent syndrome. So for each of these years by person, you can then model basically the transitions from one stage to another one, and you can model the transitions from one syndrome to the next syndrome. So tricky thing. So the core of this type of research and cohort studies that look at longitudinal patterns is that you build your data in a person by year, or sometimes if you have a study that has even, not yearly, but maybe monthly intervals of examinations, a person by month data file from the very beginning. And then the advantages are you have a tremendous increase in power, and you can work even with relatively small cohorts and do very sophisticated longitudinal statistical modelings, and you can look at the transitions. And you can also solve much better the problem that sometimes you lack data. Sometimes a person doesn't show up. And then you have a hole in your data structure. And if you have a sufficient number of people, of course, what you can do is you can estimate for a person, let's say, that hasn't participated in the second wave, what would be the expected score, let's say, in a certain part of assessment, given his behavior before and after that missing value. So this is something that you might like to go deeper into. So let me give you just an example in the next part for 2 areas, and then we can decide what are the areas we want to dig into. Of course, you have a much easier life. Your patients come to institutions. And you have also populations that are likely to stay with you. Like if you're a good doctor, if you provide good treatment, people like to come back to you. So they stay with you. Your attrition rates hopefully are not that big issue. Imagine here in this study, in the general community, you have to fight that people are not getting lost, Because if you lose more than 50% of your population, the study is not anymore really representative and strong enough to make any claims. Now, who is interested in substance and who is interested more in kids? Kids tradition. The kid stuff is of course a bit more complicated because there we model family genetic associations. Here we are looking more into substance dependence things. It's an interesting lesson because the outcome of this is, after 20 years of modeling the data, we still don't know that much. although the results are fantastic, you know, many people made beautiful PhD theses and the papers were published in good journals, but basically, at the end, it's not that exciting. But I can maybe gloss through briefly because it's pretty simple. In our sample, we have baseline data, follow-up 1, follow-up 2, follow-up 3 data. And at each of the waves you can of course see what proportion of our sample has a certain disorder. So you see here the alcohol dependence stuff. In the baseline it was 10% with abuse and dependence. Then you had a little bit more. The high value was here at the second follow-up. At the third follow-up it was much lower. Yeah? For nicotine dependence, pretty much a stable picture. Yeah? Almost 20% of our sample were nicotine dependent. Cannabis use and dependent was about 3 to 4% at each of the waves. Other illicit drugs were about 1%. Any substance use disorder, yeah, increasing here as a result of aging. And this drop is a real drop. The proportion of adolescents and young adults going through transitions even of dependence of alcohol or of other drugs and then remit entirely and completely is substantial. In that age, the stability of an alcohol dependence diagnosis is not that high. No, that was one of the lessons. Okay, so this is more the traditional picture, and this is now how the data look really like. So this gives you now for females the proportion at what proportion of our sample started to use alcohol for the very first time. And you see basically it going up to 1. Among females, after age of 9, 8, some people start here. But by age of 14, actually, every female in Germany has gone through alcohol exposure. And after age of 14 up to age of 18, 50% have established a regular alcohol consumption pattern. And the rate of people having alcohol dependence among females is minimal. Now for females, you see a completely different picture. Excuse me, this is nicotine, where are the males? Here. There you see even a substantial rate of alcohol abuse and dependence. But what is interesting, the incidence for dysfunctional patterns is limited to a very small time window here, to 3 years. There are no increases in alcohol dependence rates in terms of new onset after that age. For nicotine, pretty much the same picture. So this is what we call an incidence characterization of substance use patterns, including dependence. And you can do this for cannabis, and you can do this for other illicit drugs, and I think I don't go into that. And what the German government actually and the prevention people were interested in is, okay, if we want to lower actually the alcohol problem rates and the cannabis and drug rates and the nicotine rates in Germany, what is the critical target, the time window where we have to intervene in order to prevent these high numbers of dysfunctional outcomes? And as you can see is whatever starts with 14 years old in school will actually result in an increase. And some of you might have read my papers 15 years ago that most of the prevention trials in schools for eating disorders or substance use will increase the probability that the kids will start, you know, with the clinical picture. It will not decrease. People who otherwise would go unaffected are stimulated to try it, whereas those who try it as a problem, they don't care. You know? So you basically do no good by this type of school prevention when you do it in the wrong time window. And based on this, actually, Germany has adopted a completely different strategy. We do not do any school prevention programs at all. And actually, since then, together with legislation, the smoking rates have decreased by 60%. The dependence rates, particularly among females, has been broken as well. And the same thing with cannabis. We have gone down from 50% exposure cannabis now to 18% right now. And simply because of targeted intervention rather than what we call universal prevention programs in schools, which are very costly and don't work. So it really pays off to do this type of things. And it's a really success story of this type of studies to do it. Okay, so let us briefly, well, let me show you one other thing that might be interesting. Transition analysis. So one thing actually where most substance use people who deal with clinical populations say, if you have an alcohol problem, you know, the transition to develop dependence of alcohol is taking a couple of years. You know, I was educated like this as well with Jelinek. What we found out is actually the time lapse from first use to developing abuse or dependence is very fast. Much faster than most people thought. And it gave us actually, linked to this study, a second program where we looked into what are the predictors of this fast transition and what does it do to the brain of the people. So we're doing a lot of imaging study where we look into people who started with the first use and then transcend to dependence or stop it entirely just to see what are the brain imaging changes that we see in these people. And what you see actually is that the regular from first use to abuse, average of 4 years, to dependence also 4 years. So the transitions are pretty fast, which means you do not have that much time if you want to have targeted prevention to prevent the person from becoming a case. And that is a pretty interesting result actually that I believe was very instrumental. Let's go to the disappointing part. If you look at these patterns, of course, you want to understand what are the risk factors. And we were so naive thinking, okay, we did everything. You know, we looked at family genetics, age, gender, schooling, social class, urbanicity, self-esteem, coping, behavioral inhibition, peer, etc. Everything. Everything is in our study. And we look at protective factors and we look at risk factors. And so our thought was basically, if we can predict using these things, the first use, the repeated use, the regular use, and the dependent use. And we can see what predicts discontinuation and polysubstance use. And well, as you can imagine, it's tricky and it doesn't work that well. So we published a lot about these things. You know, it's because if you look at the factors, you find out, ooh, it's different in males and females. Doesn't bring the colors. This is onset of regular cannabis use after baseline. And you see actually there are factors, there are many factors typically that are associated with it. Some as risk factors and some are protective factors. So high self-esteem is a protective factor that prevents the transition from first use to become a cannabis abuser or dependent user. But you see also here parental mental disorders of any type increase your probability of becoming a case. Regular smoking before age of 15 is a risk factor. Poor family climate is a risk factor, and so on and so on. Anxiety and mood disorders, daily hassles, everything. So you see it's getting quite complex, and if you model this, it gets not pretty much different. This is a list of all the factors that come out as significant predictors. You know, everything. Everything can be a risk factor. It depends on how it gets together. And it doesn't help to model genes in there. It's getting even messier, you know. And so it was really, so ultimately we came up with a very sophisticated longitudinal modeling, 3,000 people, probably the best vulnerability and risk factor study ever done, and came out with a model that predicted actually dysfunctional problematic use of substances. Very good fit indicators and whatever. But what do you do with this? It's academically, it's fantastic. It was a lot of fun to do it. But it's terribly frustrating if you want to dissect something, what needs to be done out of this thing. It's very academic. It's things that basically, you know, every clinician said, I knew that from the beginning. Of course self-esteem plays a role. Of course if it's not available, it's not, I mean, it's so difficult, you know, to dissect really what are the mechanisms. So I believe one lesson from this type of broad spectrum research is really you learn a lot about how complicated and variable the developmental pathways can be, and you also see which factors repeats itself in various type of disorders. But really understanding the individual mechanisms, the fate of people in these pathological pathways is a very different story, at least when it comes to substance use disorders. So we were pretty disappointed actually after all this in this particular area. So, any questions to that? When you want to read about this, including some of the editorials I wrote about the limited value of these things, most of these papers have appeared in alcohol and drug and alcohol dependence in the this was 2002, 2005. So between 2002 and 2006, and they look at cannabis, they look at alcohol, they look at ecstasy and very dysfunctional stages of alcohol dependence. And the more you go into the end 2000, then you see in the editorials that I wrote with that I believe that type of research does not really help us answering the core questions. What is more exciting have been these type of things, because they give rise to a series of cohort studies that we have started in conjunction with this. So for example, I have one cohort study where I have 300 females that have no depressive disorder but who have a long history of anxiety disorder. And basically, when they get pregnant, they get enrolled in the study, and then we monitor the pregnancy and then the development of the child over 20 years in order to see what is the effect of this anxious behavior of the mother on the unborn and later on the born child in terms of subsequent problems. So, and what was so surprising here in this kind of thing is that there was such a tremendous degree of familial aggregation in our study. Now, just to give you the framework here that we dealing in this study is basically when we look at depression as an outcome, we knew already that there are many factors, and we knew a lot from previous studies about the interaction of these levels prior to the exposure with events. And we knew that studying patient doesn't help us, because when you study patients, you have the confrontation of the acute and the long-term consequences, you know. So I believe actually depression research and bipolar research should actually work in the healthy phases of the people in order to see what is happening in the before actually an episode starts, to see this interaction more clearly. So what we did is the following thing. Let me see whether we can have that. So the traditional way of looking at these familial aggregation as a first step is that either, you know, you pick depressed patients and then you look, did the parents also have it, or you take depressed parents and you look what the children have. Now this type of research is pretty easy to do. You know, you have patients and then you just try to get the relatives. But it has a lot of problems, of course. the difficulties, of course, are you have selection effects of all kinds. And of course it would be easier if you have a prospective kind of study where you basically have a representative sample and you see what is the true association between it. And this is what we did basically. And the second thing we have learned, you cannot do it for one diagnosis, you have to do it for several diagnoses. So you have to look at the interaction of psychopathology. Like anxiety and depression are closely related, so we know that there might be effects like the parent might not have a depression, but it has an anxiety disorder and it comes to the same outcome. So this type of association is of course very interesting to look at because you learn a lot. And let me, because of reasons of time, let me say what we try to do. We try to do in this sample to look what is the role of parental depression if assessed by direct parent interviews and family history information. We look at perinatal factors, we look at the role of somatic mobility of the child, and then look at various childhood factors, including the family functioning and family climate, assessed retrospectively and during our various assessments. So, the first thing that you see clearly is among males, if you have no depressive disorder in the family, including actually, it's actually, should be, yeah, we also excluded actually all bipolar cases here. So hypomania and mania cases were excluded here. You see this from the, it says 3,200, but it should be 2,400. Yeah, you see this here in the numbers. They're smaller numbers. So what you see here is basically that if you have no parent that ever had a history of depression, the risk for the child was 14% to have a depressive episode among males respondent. If there was at least one person with a lifetime history, yeah, it can be one single episode, the risk doubles to 24.6%. For dysthymia, the risk increases larger. So if there is dysthymia in the females, then among females it goes up from 2.1 to 6.9%. The same risk elevation is there for females, but females are more likely to have depression. So here you see the numbers are a bit higher. So the risk increase is about twofold, and you have 22 without and 36.7 with this exposure. Here, pretty much the same picture as before. So, how does it look like? Because, again, the question is, what you going to do? Again, what we model now here is, at what age, actually, people have their first episode of depression when there is no family genetic factors. These are the males. And you see, okay, the depression, there are few cases before age of 16, and then the increase in incidence happens here for the first time between ages of approximately 16 to, let's say, 22 or 23 years. What you see in the affected kids, that the onset of depression is much earlier, and then ends up with considerable higher rates. For females, we see, and that is consistent with the clinical knowledge, we see a lot of depressed girls at an earlier age. So here we see a significant shifting forward of the risk to become depressed. So this is a major effect, by the way. It's much stronger than any other risk factor in medicine normally, where you would say, okay, if you have a depressed father and mother in the family, lifetime history. I'm not saying here that the person has to have it at the time where there is contact between the two persons. But then you basically see that there is a substantial proportion that has it quite early, already before age of 12, and then there is this tremendously strong increase later on. These are considerable risk elevations that really should prompt the issue screen for depression among the parents and try actually to reduce the harm for the kids. Does it matter whether you have both parents that are affected? Well, you can see yes, it does, but it's not that much larger. The effect again occurs early in years with the very early onset. So the onset, the risk to become depressed for the child is shifted to earlier ages. Yeah, and here you see basically the comparison once again, and you see the age of onset curve, if you have a familiar component in your depression, shifts the onset of depression to earlier ages. That's the major effect that you can see here. So why is it that this happens? This is the question. Well, we also looked into what type drives this association. Is it, we looked at suicide attempts, recurrence risk, persistence, impairment, melancholic features. Maybe we drop that. Well, the summary was the association is significant for males and females. The familiar depression starts earlier as compared to the non-familiar depression. Little additional effect if both parents are affected in terms of the risk, but as you might remember, it shifts things earlier. Recurrence risk, number of episode persistence, and particular melancholic features are familiar as well, but there's no significant differences. Any depression increases, even a short-lived past episode. So it really is important to screen for the lifetime history of depression in families, not just whether the mother has it when she's dealing with the kids. And parental anxiety disorders are also familiar, and I come to that in a minute. So, let me show you here. So our archives publication was basically, kids should be much more careful in choosing their parents, you know, because it's too risky. And obviously there is too much going on in this field that we should run. So the question is, what should the kids look out for? What is it what they should look at? And so we now look into what drives the effect of depression. Is it perinatal factors? Is it early somatic disorders? And what other areas are dysfunctional before the people get their depression? So this is one factor that contributes to a certain degree. Early somatic diseases of the kids, in terms of, is there a higher risk before that actually there's a mediator in terms of being ill? Doesn't count. Early mental disorders, yes, and particularly ADHD and enuresis, so elimination disorders. They are actually the ones that for depression are pretty specific. And then there is what we call marked affect lability, that is the childhood behavior, a lot of tears and whining, crying spells of the baby when it was young. And as a temperamental factor, behavioral inhibition came out quite nicely. Now, which is the one that is of most interest? Well, probably the one that you can intervene. And, oops, backwards. So we looked actually, do the parents in our young respondents show a different pattern of behavior? So, and among affected patients, what you see is overprotection, emotional warmth, and rejection have an association with the incident episode of depression. Not the degree of family functioning so much, which is basically how well the functioning is family. This doesn't matter so much, but it's particularly the overprotection of the mother in combination with rejection. Now, for those of you who work with schizophrenic patients and families, pretty well-known finding. You know, it's a mixture of being overprotective and rejective that obviously creates a climate where the young organism doesn't develop that well and might lead to increased stress exposure in terms of not one-time stress factor, but more in terms of a chronic adversity factor. And let me just summarize. So children of depressed parents are at increased risk for having perinatal complications, developing early childhood conditions in the field of mental disorders, have marked affectability as perceived by the parents, and they're also significantly more likely than kids of unaffected parents to be behaviorally inhibited. Parental rearing style and dysfunctional family functioning reveal further substantial significant effects on depression risk in the offspring, and the effect is significant, however, only among offsprings with depression parents. So parental warmth has a significant protective property in both affected and unaffected offspring, but is particularly powerful in children with depression. So that is an example from that field, and I don't know how much time do we still have? Not a lot. So let me then come to the conclusion. Let me see whether I have a funny slide to close with, so to cheer you up a little bit after all. Let me see. Yeah, I like this one actually. It shows you longitudinal research is a frustrating job. You do something for many years, you have to maintain a very high level of methodological correctness and stability. You have to maintain a high degree of reliability standard that is typically boring, you know. If you work with patients, you know, you try to be a good clinician, you try to help, you try to do certain things. And being reliable is certainly not a quality that, that necessarily helps a patient a lot. So, and I know this is very painful, but it pays off. It pays off because the effects you're getting depend heavily on this. This is an example where we, at one stage in the methodological paper, have looked in those interviewers where basically we do some audio taping irregularly, and then we estimate basically to what degree did that person comply with the protocol in the assessment. And what we find out is that the group that is highly reliable, these are pretty much the boring staff members, you know? No, really, I mean, these are not the nice, I mean, I'm not reliable, you know? Yeah, it will be very hard for me, you know, to do even my own interview exactly the same way for 2 or 3 years, because I just think too much, you know. So it has nothing to do with your personal quality. It has to do with doing the job right. And those people actually who are able to stick to the rules over 2 to 3 years, or even sometimes 6 or 7 years, or 10 years in some instances, they are the ones that produce stable results. We had originally included all kinds, also the so-called proxy interview findings, which are those where people with miserable reliability ratings were included in the analysis. If you do it in this type of study, your significant effects go away. And this study is just powered enough to assume if you have, like, say, 2,400 parent-kids pairs, to detect differences and interactions between disorders. And if you lose even there, like 50 observations due to unreliability, your effect is gone. So it really pays off, and I hope in your network activities that you are pursuing, you will have always this in mind, that sometimes the innovative and very creative researchers are not the best interviewers to do assessments. And when you work towards reliable assessments, sometimes it pays off to look for those people who do it very reliably and who are able to appreciate that the sticking to the rules, conventions in your projects are essential for good science. I hope this is fun for you. Thank you.